Thank you very much for the invite, AIOS, and to Dr. Natarajan and Arupda. It's great to be back home, and actually Indore is home for me, so Delhi College is my school, and medical college as well. But what we are here to celebrate is 200 years of ophthalmology in India with the institute in Chennai, which was built just a year after Moorfields Eye Hospital, which happens to be another of my alma mater. So what we're going to talk about is a few concepts in the glaucoma surgery nowadays in the next 7-8 minutes. So Peng Ko, my mentor, would say that we need a surgery which has pressure of 10, surgical time of 10 minutes, and lasts for 10 years. And I've added a few of my own as well. But unfortunately, there is no surgery which can achieve all these requirements of ours. So there is no glaucoma ideal surgery as yet. All over the centuries, all we have done is lower the pressure, and that's all we can do at the moment. We probably have neuroprotection in future, but we don't know. So we can either increase the outflow within the eye or outside the eye, or reduce the inflow. So when I became a consultant in 2009, I had only these 6 or 7 options which I could do, and these are still some of my favorite options. But now in 2019, I have nearly these 16, 17 operations available to me, including outflow procedures, inflow procedures, and still, those old procedures still remain my favorite, along with phaco ECP on top of that. We have all these new devices which have come in the market, and we have used all of these in our institute as well. CyPass has now been withdrawn because of endothelial concerns. So I'm just going to share a quick case study with you. 45-year-old chap with very high pressures of 60 and 50, with steroids and very advanced glaucoma in one eye and very early glaucoma in the other eye. So when you have a very real glaucoma like he has in the right eye, you need real surgery, and that is trabeculectomy at the moment. And he's doing really well after that. This is 4 years since the operations. And the other eye we did phaco and eye stent, and again he's doing well for that eye. But obviously it doesn't achieve very low pressures. So this is eye stent G1 going into the Schlemm's canal. And once the eye stent goes in, you see a bit of reflex of blood where you know it's in the right place. And sometimes in clinic you see this reflex as well, again telling you it's in the right place. But they do tend to scar and doesn't work very well. And this is the Zen stent. Again, this is the ab interno external implant going underneath the subconjunctival space. And again, these have their own complications, and the success rates are less than 50%. So we have reviewed all the mixed devices with phaco, and we find that there is a floor effect of about 15 pressure with any of these devices. So you don't get very low pressures. And they are very expensive, nearly costing 50,000 to 100,000 rupees. So they're not really applicable for the rest of the world or for everybody. We reported the first case of endophthalmitis with a Zen implant as well. So in summary, if we talk about just the MIGS, then it's work in progress, and they're only for early and moderate glaucoma, and there may well be scope in future. But for me, trabeculectomy still remains the gold standard for glaucoma surgery. And a well-done trabeculectomy achieves the right level of pressure, and it can be made safer with the new techniques like the Moorfields Safe Surgery System. But actually, if you look at the development of trabeculectomy over the years, how it's happened is that sclerostomy came first, and then Colonel Elliott in Chennai, he actually modified it to become a corneosclerostomy. And he brought the sclerostomy edge forward. And then John Keynes, in his paper in 1968, mentions that Ilias procedure is now being modified by making a guarded sclerostomy. So that is exactly what trabeculectomy is at the moment. A guarded sclerostomy, a partial thickness flap guarding the sclerostomy or corneosclerostomy. So India played a role in that because Colonel Elliott developed this trephine here in Chennai, and that's what we are celebrating today. So the TVT study showed that the tubes work better when you look at the 5-year results. So we thought, why not look at the primary results for primary surgery? So I was lucky to be part of this PTVT trial, where we recruited over 250 patients around the world, or 240 patients around the world. My mentors Keith and Sheng were part of the trial as well. And in fact, half of the patients came from 3 of us in this trial. And the first year results showed very good pressures of about 12 in the trabeculectomy group, which was lower than the tube group, with better success rates. The failure was higher in the tube group. And the 3-year results will be presented at the AGS this year. So what we find is that in the PTVT trial, the tube had more failures, wherein the TVT trab was more failure. So we looked at why this could be the reason. One of the possibilities is that we are not using mitomycin for tubes. So that's the new study we are doing now. We've recruited 24 patients, which is comparing tube versus trap with MMC and without MMC. So for me, current indications of tubes are failed trabeculectomies, difficult eyes where the success of traps can be limited. This is another trial which I've been part of, is treatment of advanced glaucoma. We've recruited 440 patients, medication versus trabeculectomy, and we're due to report soon on this one. So what about advanced glaucoma with high risk of trap failure? So in these patients, I do a combined surgery, which is a trabeculectomy and tube. So we put Embarvel 350 with mitomycin, and this is not minimally invasive, it's maximally invasive for these high-risk patients. And we put a ligating suture and a supramid stent suture as well. We've shown good results in our hands, and we are going to present this in ARVO this year. So for me, if one take-home message is there from this talk, is that pick up the progressive glaucoma and refer these patients or do the surgery early rather than poisoning them with more and more drops. Because the first success of the operation is the best when the operation is the first time. You don't want to be putting too many drops and then the patient or the eye is very ill and then the success of trabeculectomy is really poor. We really need to use our bar very judiciously. So what can be combined? We can combine maybe a wine at dinner or maybe, but not everything at the same time. Otherwise, we will be sick just like this. So another of my mentors, Paul Foster, was instrumental in these trials, and I'm just going to touch on these very briefly. So is lens extraction helpful in angle closure, and is PI helpful in early angle closure or suspects? So the EAGLE study, which again I was part of, was published in 2016, and it showed that the lens extraction is very effective and gives better quality of life, better IOP control, and is more cost effective as well. So it was a very pragmatic trial, but the key thing is that these are angle closure patients with pressures over 30 or primary angle closure glaucoma. So these are not patients with any angle closure, it's only with established disease, with a 3-year follow-up. And 60% of the patients after just lens extraction don't require any drops afterwards to control the pressure. And you can see why. As the lens grows in the eye, it has a big effect on the anterior chamber, and once you remove it and replace it with the IOL, there's plenty of space and increased outflow as well. This is very briefly ZAP trial, which is going to be published in Lancet very soon. 889 patients who were randomized to PI and a fellow eye control. And it basically shows that you need a lot of patients to prevent angle closure. And they are going to say that it should be offered only those with highest risk of primary angle closure glaucoma. So our traditional thinking has been that PI is very good, but actually what the trials showed, lens extraction is very good and PI has a very limited role in very early stage disease. So this is another new technique which we have started called phaco IOL and ECP, along with endoscopic synovial. So these are patients with very advanced angle closure with very high pressures and who have got more than 360 degree of synovial closure. So from this very brief, in 8 minutes I can't cover everything, but take-home messages are mixed. They are only for early glaucoma, they are work in progress, and they may or may not be cost effective. Trabeculectomy remains the gold standard. First surgery has the best chance of success, they refer them early. Tube surgery is reserved for complex glaucoma, and lens extraction is very effective for angle closure. Thank you very much.